All right, thanks for coming out, everybody. So the topic of tonight's talk is Concussion 101. So this is kind of introductory lecture to concussion, the disease process, the evaluation, management, treatment. I do have some of the colleagues from our concussion clinic here at Casa Colina who are going to give some additional talking points for you. This is just kind of the broad overview lecture of what is concussion, what do we do about it, and we will be kind of building on this through further lectures and delving more a little bit into detail about some of the latest and greatest and other facets of concussion because it is a big topic. So without further ado, here are some of the objectives for tonight. So first, we're just going to describe and define concussion, and then we'll talk about some anatomy and kind of what happens in the brain after someone suffers a concussion. And we'll talk more in depth about symptoms and management. So first off, what is a concussion? Let's make sure we're all kind of on the same page about what we're actually talking about. So I really like this definition from the American Congress of Rehabilitative Medicine. It's one of the national groups within rehab. So they actually, interestingly, you see it says mild traumatic brain injury there. So there's a lot of kind of discussion in this community. Is that an interchangeable term with concussion? And ACRM does use it interchangeably, okay? So you'll hear different kind of viewpoints on that, but as far as the American Congress of Rehabilitative Medicine and many other bodies are concerned, mild TBI is an interchangeable term with concussion, okay? So they define it as someone who has a traumatically induced physiologic disruption of brain function. And then that can manifest as some of these beautiful acronyms. We love acronyms in medicine. And LOC would be loss of consciousness, AMS, altered mental status, so not thinking or remembering things appropriately, amnesia of the event either before or after, and then GCS. GCS is the Glasgow Coma Scale. It's basically a quick survey of how someone's brain is functioning, and the higher the score, the better. The highest score is 15, lowest would be 3. So you have to be in the higher ranges of this GCS exam in order to qualify as a mild TBI or concussion. Now, I did highlight the number 13 here because there is some controversy on the GCS 13 number, because what the latest research has shown is that people who have a concussion with a GCS of 13 actually kind of have a different prognosis and kind of follow-up than someone who has a GCS of 14 or 15, 15 being totally the highest score that you can get, okay? So I just want to say things like this are changing all the time, right? This whole, is GCS 13 really a mild TBI? Is it really, within the concussion spectrum? Things like this are changing all the time. How we kind of assess and address things like this clinical issue of this has been the definition for 20 years. They're always changing. So it's important to kind of stay up to date on all of that and get educated on it so that we all, talk the same language, so to speak. And then I do also want to highlight brain imaging, right? So not required for a diagnosis of concussion, okay? And it's oftentimes normal. Even some of the best imaging we have, right? MRI is the best kind of resolution picture we have of brain tissue. And it does not rule out concussion, and it's not needed to diagnose concussion or mild TBI. So why does concussion happen, right? Digging a little bit more into some of the anatomy and pathophysiology. So couple different ways that a concussion can be caused. So obvious ones that we think about all the time, right? Your head bouncing off the ground, hitting a wall, an object like a ball flying into your face and causing a traumatic impact. But then also, really importantly, and this is another thing that's come out in some of the more recent research, acceleration and deceleration, right? So any kind of motions like this, twisting, you do not have to actually impact your head, right? There can be trauma within the skull. There can be trauma of the brain tissue impacting onto the skull, as we see in this picture, without an actual blow or strike to the head, okay? So definitely an important piece there. And then what happens within, as I mentioned, the skull is fixed, right? It's hard, it's bone. And we think of it as being pretty smooth inside, but there's actually quite a few little bumps inside of the skull where your brain sits. And your brain is quite soft and squishy. It's almost like a jello-like consistency. And when it gets rattled around, either by getting impacted or by this acceleration deceleration, it's rubbing around on all those little bumps inside of the skull, which causes a couple of things to happen. So there's primary injury and secondary injury. Okay, so primary injury is when the brain is actually impacting onto the skull, and that physical impact causing a bruise, right? Just like if you hit your arm on a pole or the wall, you'll get a bruise there. Same thing with the brain, right? It impacts the wall. There can be a little bit of bruising of the brain tissue itself, okay? And then secondary injury would be subsequent effects of that primary injury, subsequent effects of the impact of the brain on the skull. And that's when we talk about neuroinflammation, inflammatory cascades, basically your brain sending a bunch of what will eventually be healing factors to that area, but first has to cause an inflammatory reaction in order for that healing to eventually occur. And that ties in nicely with the next point on concussion occurrence and second impact syndrome. So second impact syndrome is when you have a concussion and then this inflammatory process is ongoing, and then you have another impact to your head while that inflammation hasn't fully resolved, and can cause basically this explosive cascade of inflammation, which can cause brain swelling, can cause all kinds of more serious complications. And as far as the time frame for that, usually it's very quickly after the concussion, right? So generally we'll see it within a second strike to the brain, hours to days after, but there have been case reports out to 2 weeks, right? So 14 days is about the longest time frame that we've seen in the literature as to when this second impact syndrome can occur. How is it diagnosed? So I want to emphasize that first point really strongly. It's a clinical diagnosis, right? As I mentioned, there's no specific lab testing, there's no imaging testing, there's no specific fancy computer application that can tell you this is concussion, right? It's a clinician, it's someone with expertise in the full spectrum of concussion symptoms, presentation, history, physical exam, implementing perhaps some of these tools for additional information to put it all together and confirm, is this concussion, is it something else, right? So many of the clinical guidelines, the CDC guidelines say no one tool should be used to diagnose concussion, right? You want to take everything together and make sure that you're providing a comprehensive evaluation of that patient and making sure that you're not missing something else that's going on, make sure that they're not having symptoms that are similar to concussion that aren't actually related to that injury, okay? So that's why I mentioned excluding other diagnoses, brain imaging, especially some of the more advanced techniques. I'll say they're not, so fully kind of endorsed, or we haven't completely honed in on exactly which of these techniques and how to interpret them, but just know that we're doing a lot of research in the concussion community on advanced imaging techniques to help aid in our diagnosis of concussion. So I mentioned two here, diffusion tensor imaging, which is a form of MRI, and then a PET scan, which is basically where they put specific tracers into your brain, see where they go, see what they light up. So it is a much more kind of advanced way of evaluating the brain, but we're not quite to the point where we can use it routinely in concussion diagnosis. Also biomarkers. So biomarkers would be blood tests or other, molecules that we can see in the blood or in the brain that would, again, be elevated or be decreased after a brain injury, right? So like in anemia, your blood levels are low, right? Your hemoglobin is decreased. That's a biomarker for anemia, right? Similar to concussion. There are a couple of different molecules that they're looking at. Can we test it in the blood? None of them have been, kind of entered into the mainstream yet, but I think we're getting closer to being able to use those consistently. And then I do highlight a couple of the computer-based systems that you'll see used out in the community, especially in the sports community, impact testing and sway testing. So both of those are computerized evaluations of balance and memory and reaction time, all of these things that can be affected by a concussion, and put some kind of more objective data to some of those systems that are affected after a concussion. So you'll see those are the two most common ones. There are a couple of other computerized systems. And then non-computerized, there's a couple of different assessment tools as far as certainly for sports injury. The SCAT-5 is kind of the gold standard, the one that's I'd say most commonly used. And it's free, it's available online. It's just a series of questions and exams that we administer to patients, and you can do it on the sideline. You can do it when they present post-injury for evaluation in your clinic, and then you can do serial exams to track their recovery. So the SCAT-5 I would highlight as another really good assessment tool for concussion. All right, so once we know a little bit about the tools, we can talk more about what the symptoms are, right? What are some of the things that we're asking about, evaluating, tracking for recovery? A little bit small, but you don't even really need to read the list. You can just see that there are a lot of different symptoms that can be associated with concussion, right? Because of all that little micro injury to the brain, because of the general inflammatory process within the brain, pretty much any brain function can be affected, right? So this is directly from the SCAT-5. This is the symptom checklist that's included with that. And this is one way that we can kind of keep track of the severity and again, monitor it as people recover. So I would just like to emphasize that no two concussions are the same. I've never seen two of these profiles as people are circling, you know, how severe their symptoms are on any one of these given symptoms. Never seen two that are the same, right? So everyone's a little different in how they experience, how they feel after a concussion. So a couple of the more common symptoms that I'll just highlight from this list, the headache, associated neck pain, and the high concurrence of whiplash injury or sprain of the neck muscles and tendons after a concussion, and then are associated with a concussion, dizziness, blurred vision, feeling like you're in a fog, just don't feel right is one of the questions. And I love that because it's a general kind of assessment. Are you feeling okay? Are you just generally not quite feeling like you did before you hit your head? And then irritability, confusion, drowsiness, and then sadness, anxiety, feeling nervous, trouble falling asleep, insomnia. Those are some of the more common symptoms and some of the ones that we really want to make sure we're assessing for and addressing. The other things that I like about this SCAT-5 and this symptom checklist in general, it asks if it gets worse with physical activity or mental activity. Really important to get a sense of as we try to get people back to their normal function, back to their day-to-day life. And then, so improvement, right? What's the timeline for these symptoms resolving, right? Because the natural course of concussion is for symptoms to get better with time, right? And so the brain is really good at healing up inflammation. Our bodies heal up inflammation all the time in every single system. Same is true for the brain, right? Your brain can heal up inflammation. It can recover really well, actually, from a concussion. But it doesn't always do so. As we can see in some of the newer research, initially, you know, we would say pretty much everybody should be better at around 14 days. When they look at larger populations, populations of patients with concussion, it really shows that only about half of people are completely recovered at 14 days. By 28 days, we're much better. 85% of people are kind of back to their baseline. They're feeling 100%. But then there's this 15% of people which have more prolonged symptoms, right? And those are the patients that we really want to make sure we're finding, diagnosing, and treating appropriately, right? Because that prolonged post-concussive syndrome, right, which is how I would classify this 15% with symptoms that are ongoing beyond the kind of natural recovery timeline. You know, if you don't address it actively, then it can just persist, linger, and not get better. But with appropriate treatment, rehabilitation efforts, we can make a lot of progress in making the post-concussive patient feel better. So common question, especially, I do sideline coverage for a local high school. And so the question often becomes, when do I see my doctor? When do I need to go to the emergency department? What do I need to do from here to make sure that, my child or, my loved one gets the attention that they need for the concussion? So anyone who's even suspected, right? Even if they don't have much in the way of symptoms, but they have the mechanism of hitting their head hard, either from a fall, from a sports injury. If there's any suspicion that they might have had a concussion, they should be assessed, right? They should see their doctor. They should be evaluated by someone who is experienced in diagnosing concussion. And I think for a long time, concussion was really underreported, underdiagnosed, and that is still to a certain extent the case. But there's a lot more attention being placed on concussion right now, which is ultimately a good thing. And I think there's a much greater amount of awareness in the community that whenever you have any hint or inkling that you might have hit your head to the point where you suffered a concussion, you need to get that addressed right away. I'll also highlight some of the red flags. So these are basically indications that there's either a more severe head injury or, again, something else going on. And that basically says you really need to get to the emergency department right away and get checked out more closely, get the brain scan or whatever else you need to make sure that you don't suffer a more serious consequence of the concussion. So severe neck pain and tenderness, double vision, weakness or tingling in the arms or legs, increasing headache, it's just getting persistently worse and worse and worse, and it won't abate at all. Seizures, convulsions, any loss of consciousness really should be referred to the emergency department for further workup. If they're consistently declining in their conscious state, meaning that they're, basically it's not falling asleep, but they're less and less responsive. Let me put it that way. Vomiting, restlessness, agitation, combativeness. And then also, I just kind of like to highlight some of the observable signs, right? So balance, gait difficulties, even just a blank or a vacant look, right? This is, again, from the SCAT-5, things that we're looking out for on the sideline, specifically after someone has a hit or has any symptoms of concussion. And this is really important, right? Because as we saw with Tua Tagovailoa, the quarterback for the Miami Dolphins, right? He was stumbling around, right? He had the balance and the gait difficulties, right? Gait ataxia, motor coordination. He had those symptoms. They took him off the field, and then they said, oh, no, he just sprained his back, right? But no, that's not what's going on. He had a concussion, right? So that's why we need to ask about some of these more kind of outside of the normal realm of what we might think about somebody experiencing after the concussion to make sure that you get assessed and treated. All right, so getting to my favorite part, what is treatment is available, right? So point number one, this is one of the first things that I learned in medical school. As doctors, our primary function is actually just to remove barriers to healing, right? The body knows what to do. It's trying to heal. All we have to do is remove the things that are keeping it from healing, right? So lack of high quality sleep, right? Substances, alcohol, tobacco, even some medications, right? Benzodiazepines, these anxiety medications can slow and inhibit the recovery from brain injury. So you want to make sure that somebody is looking at all of those potential barriers to your brain just doing what it wants to do and healing up with time, okay? And then the next lesson that I learned when I started residency is that rehab requires a village, right? It's no one person, it's no one doctor, no one clinician that is going to be able to address all of those various symptoms that you're experiencing after concussion. It really does take a team to treat concussions effectively and to treat post-concussive syndrome effectively. So there's no medication, right? There's not a concussion medication that I can give somebody to heal up their brain after, you know, they hit it on the wall or the floor. There's no supplements that have been proven consistently to improve the symptoms or to heal the inflammation in the brain. Again, active area of research. There are some supplements that have shown promise. There are some things that, you know, probably won't hurt anything and may help something. But that's all on an individualized basis, right? What other medications is the patient on? What else is their past medical history? So there's a lot that you want to take into account before you go starting any supplements and any medications. There are, of course, medications for symptoms, right? Medications for dizziness, medications for headaches, medications for sleep. And, you know, in general, I would just say we follow a conservative and stepwise approach, okay? So we want to start with the things that cause the least potential harm, the things that, you know, the rehab efforts, everything that we can help in their environment, in their living situation, to help their brain heal up, and then introduce more aggressive therapies, more aggressive medications, if the conservative measures don't end up getting the results that we want. This graphic here is just kind of a general outline of what we have in place here for our concussion clinic. So referral sources all over the place, right? Concussion can affect anybody from infant all the way up to someone who's 100 or more. And so referrals could come from anywhere, right? Orthopedic surgery, emergency departments, athletic trainers, a primary care or a geriatrician, or a pediatric practice, right? And then basically from the concussion clinic model, you have all of the specialists that are going to be taking care of that patient to help them rehab, right? So you're going to be hearing from Dr. Cisneros, neuropsychology, neurooptometry, Dr. Quan. The eyes are very tied into the brain, right? There's a lot of information and processing that goes through the eyes, and you're going to learn all about that in a minute. So I would say neurooptometry is a very important part of concussion care and treatment. We have occupational therapy, speech therapy, physical therapy, working on balance, working on exertional capacity, and then if needed, neuroradiology, but as I mentioned, not 100% necessary. And then last but not least, physical medicine rehab, right? PM&R, that's my specialty. And we're all about helping people get back on their feet after they suffer any traumatic injury, any disability. We really kind of take the whole person approach to care and make sure that we're addressing everything that they're experiencing and getting them back to their maximum potential function after anything that they've gone through medically. All right, I would be remiss in a concussion talk without at least briefly mentioning chronic traumatic encephalopathy. Again, gaining a lot of attention in the media recently. So it's not new, right? They've kind of described this since the 1920s in boxers, right? This punch drunk syndrome. And then as they started to understand it a little better, coined the term chronic traumatic encephalopathy. So chronic means long and ongoing, traumatic from trauma. Encephalopathy is basically impaired brain function, okay? So that's what that term means. We call it CTE, and that term has been around since the 1940s, right? Also not new. However, if you look at the graph on the right, that is why it's getting so much attention, okay? Because there have been some studies about what the risk of getting CTE is after you're playing contact sports, NFL players. There were a couple of really famous cases of people who had CTE and then, you know, got a lot of media attention for that. So really interesting how this breaks down. The study on the top, as you can see, 99.1% of the NFL players in that study and 87.6% of all football players that they had in that study had signs of CTE. But you have to be careful because this was a highly selected population, meaning these were people who had symptoms of CTE and had donated their brains specifically to look for the findings of CTE, okay? So that doesn't mean that 99% of the players in the NFL right now are going to go on to get CTE, okay? So I just want to make that clear because I don't think that the news articles really honed in on that. And then when they looked at a bigger population, random brains, right? 4,000 random brains. They cut them up. They look at various stains. They look for signs of CTE. So 8% of football players, they found findings of CTE on the pathology, 5% of athletes, but 1.3% of non-athletes. Some other studies have shown numbers from 6 to 9% in athletes and 3% in non-athletes, right? And people who didn't have a history of concussion, head injury, or anything of the like, okay? So, you know, as more and more comes out on this, I think we'll understand it better, what causes it, you know, what the kind of dose of head impact and head injury is that puts you at risk for this. But it's important to note that 99% of the NFL players are not going to go on to get CTE. There are no lab tests. There's nothing that you can do to truly diagnose this until you have brain tissue, okay? So it's a post-mortem diagnosis, something you find kind of after the fact, I guess you could say. And there's a broad spectrum of it, okay? So this is a picture of 4 kind of stages or 4 degrees of severity of CTE. This one, the brown spots are basically the findings on pathology associated with CTE, 2 tiny little spots, but still you would classify that as CTE, and that would go into these statistics, whether or not they have symptoms of it, okay? And then all the way down to the severe side where you're seeing the brain tissue actually shrinking, you're seeing a much heavier burden of these little tau proteins that we see as kind of the hallmark of CTE. All right, so that's that. And I will now hand it off to Dr. Cisneros.
Hello. So I'm Dr. Cisneros. I am a neuropsychologist here at Casa, Colina. And so I thought that, first of all, it might be important to just tell you what a neuropsychologist is, because most people have never heard of one until they get referred to one. So a neuropsychologist is a clinical psychologist who then specializes in disorders of the central nervous system and how those things affect someone's thinking abilities, their mood, and their behavior. So we primarily deal with people who have neurological diagnoses and then all of the problems that can happen as a result of that. So I tend to see a lot of patients who have traumatic brain injury or dementia, stroke, those types of disorders. So, and I'm very happy to be part of the concussion clinic here at Casa Colina. So first of all, I just wanted to talk a little bit about why are there so many different kinds of symptoms that are possible when somebody has had a concussion, because I think that's something that is really confusing to folks. So, you know, if they've heard of somebody who's had a concussion and they reported being dizzy or staggering or having trouble with their balance, but then they may have a head injury and they have very different kinds of symptoms. And the reality is that that's really just a function of what happens inside the brain when a concussion occurs. So when a brain moves around suddenly, it leads to the neurons in the brain getting stretched or pulled or torn, or they're being impacted by the inside of the skull. So as Dr. Block mentioned, you know, we think about our brains as being, you know, kind of encased in our skulls, and our skulls are a wonderful kind of natural helmet that we do have. However, especially the inside of the skull in the front part has a lot of little, we call bony protuberances, right? So there's lots of things on the inside of the front part of the skull that if the brain kind of ricochets against, it can cause that damage, either directly causing a contusion or by bending and stretching those little nerve fibers in the brain, which are what neurons are. And so there are also then all kinds of chemical changes that can happen as a result of that injury. So a concussion or a mild traumatic brain injury, by definition, we almost never see imaging results that show us something. We don't see a bleed, and only in rare cases can we even see some of that stretching of those neurons. So most of it happens at the cellular level, it happens at the biochemical level, or at the metabolic level of the brain. So it changes the chemistry of the brain, and then that changes the communication between those neurons. And so because there are so many different locations and so many different fiber tracts that can get impacted, that's why you can see that every different concussion may have different patterns of symptoms. Also tends to be related to, we're all unique and we all start out a little bit different, right? We all have our natural pattern of strengths and weaknesses, kind of things that we're better at. We all have our own personality quirks, right? And so it makes sense that because we are all so different to begin with, when we have an injury to the brain, that we do see different kinds of symptoms that are possible. So one of the common things that we see after a concussion is that people tend to have trouble with their sleep. So sleep, as we all know, is so important in everything that we do, and it is such a big factor that impacts every other aspect of how we're functioning, right? If you've noticed that if you get a really poor night's sleep, how is your thinking the next day, right? It's not good, right? So just about anything that we have that causes difficulty for our sleeping, we tend to notice that then we're more fatigued, right? We also are a little slower in our thinking, and we may not think quite as smoothly or as efficiently as we would have before. So what we get in folks with concussion is that the neurotransmitters, so again, those chemicals in the brain that are being metabolized by our brain, those get changed in the process of the concussion. So there's a chemical change that happens where actually some of those chemicals actually leak out of the myelin of our brain. So there's a change that happens in the coating on some of those neurons that makes it where some of those chemicals leak out more. So sometimes what we have is just the change in those biochemicals, and that can cause trouble with our sleep. It can also just change our circadian rhythms. So sleep problems are super common with concussion. And that can take a few different forms. The most common is insomnia. So about half to 2/3 of all concussion patients will have some sleep difficulties. So that's a lot, right? That's a lot of our folks. Adolescents especially are likely to be prone to having sleep disturbance, especially early on post-injury. And as you can also imagine, for those of you who've had trouble with your sleep before, if you have trouble with your sleep, if you're having insomnia, then there's an increased risk then that person is going to get a re-injury or going to get another injury, right? Easy to imagine that when we're not sleeping well, our focus isn't so sharp, and so then we can have an increased risk of re-injury just from the sleep problems. Sleep problems are also associated with that prolonged period of post-concussion symptoms that Dr. Block talked about. So when we have somebody who is having insomnia as a result of their concussion, what we see is that the symptoms of their concussion tend to last longer and to be more persistent. So it's one reason that it's really important for us to try to address those sleep problems as they're happening. And a lot of times this is really just careful environmental management. And I love how Dr. Block put it, just kind of getting out of the way of the things that our brain is naturally trying to do to heal itself. So a lot of us have very poor sleep hygiene. We have terrible habits that don't help our sleep at all, right? We tend to read on our screens, or we watch TV or do things that kind of get our brain more charged up instead of helping it kind of get lulled into that sleep pattern. And most of us can skate by on that for a long time. But if we're having other trouble that are other things that are interfering with our sleep, then it's more important for us to address those to help us get back into a good, healthy sleep cycle. Folks who have had a concussion also have an increased risk of sleep apnea. So we often think about sleep apnea as just being an obstructive sleep apnea, but people who have had a concussion have an increased risk of both obstructive sleep apnea as well as central sleep apnea. So we might notice that they're more likely to be snoring, or they're more likely to have disturbed sleep when they are sleeping. They're also more likely to stop breathing a few times during the night and have that kind of gasping that we're all familiar with people who tend to snore. So very important that if we see that that's happening, to get that addressed, because that alone, sleep apnea, is associated basically with hypoxia. So we're really kind of slowly starving our brains of oxygen when that happens. So super important that we get that addressed. There's also hypersomnia, so sleeping too much. So that can sometimes happen. It's a lot more rare than insomnia or sleep apnea in concussion patients. But when we see that happening, that can also be a sign of some other problems that are contributing. But sleep problems are one of the super common things that we see in concussion. And then my specialty is in cognitive dysfunction. So the most common way that people describe their thinking abilities as being different after they've had a concussion is that they describe feeling foggy. And that's a hard symptom really to kind of quantify or get people to describe further, but it's really interesting that that is the description that people describe. They feel like they're kind of trying to sort through soup to get through to their thinking abilities and to have their thinking as clear as they are used to it being. Part of this is related to, in a post-concussion brain, things are processed more slowly. So as I mentioned, when a concussion happens, you actually get some changes that happen in the covering of those neurons. And that covering is called myelin. And it helps neurons communicate with each other. And so when there is damage to that myelin sheath, what you see is that information does not travel as quickly. And so we have slowed reaction times. So slowed reaction times are some of the most common problems that people have after an injury. And in fact, about 78% of patients who have a concussion within that first 48 hours will show slowed reaction times. Left to just a natural recovery, again, just like Dr. Block said, with the cognition piece, we see that that processing speed improves usually over the first week to the first 2 weeks. There are about 10% of people, when we follow them in research studies, who have objectively slowed processing speed that happens beyond that 2-week period. Again, when we have slowed reaction times, that causes lots of problems in our everyday life, right? Things like driving, right? We need to be more careful when we're driving because of that risk of that slowed reaction time causing us not to be able to react as quickly. You can also imagine that slowed reaction time is associated with an increased risk of another injury happening. And in fact, that's one of the things that contributes when we have a young athlete to one of the biggest risks for them if they go back to playing sports too soon, is that slowed reaction time is associated with a significantly increased likelihood of them getting a second or subsequent injury. Also very common are attention problems. So people describe having difficulty focusing, and that's also part of that foggy feeling, right? If I could just kind of concentrate my abilities, my thinking abilities a little stronger, I'd be closer back to my normal. So concentration and attention problems are super common. Being overstimulated by the environment. This is one that we actually think is what underlies a lot of these other problems, including sleep. So one of our brain's most important abilities is to actually filter out all of the things in our environment that aren't worth our energy or aren't worth our concentration. So even as we sit here, all of our brains, hopefully, are doing a really good job of filtering out the sound of the air conditioner, filtering out this, the the overhead lights, filtering out anything that we hear from the outside. But when our brains have had an insult like a concussion, our brains aren't as good at filtering those things out. And so people can often describe feeling like their brains are just being assaulted by too much information or too much stimulus. So we see this commonly in people who are having what we call photophobia, or they're too sensitive to light. It can also happen with being too sensitive to loud sounds or just a lot of activity in their environment. And really, it just is a situation where the nervous system is really just overactivated. So it's kind of on edge, basically. People with a concussion are also very likely to have difficulty coming up with the words that they want to say. So they find themselves kind of stumbling or not being able to express themselves as well as they usually do, and just feel like they have it, oh, I've got it on the tip of my tongue, but I just can't think of the right word that I want to say. We also see a lot of difficulty with more complex tasks, like kind of problem solving through how to solve something. Especially in our younger folks, we're especially likely to see problems with impulsivity as well. So I would also just like to point out that one of the other things that we notice in folks, especially older folks who have concussions, is that this can also exacerbate or underline or make more obvious if there is already some type of cognitive dysfunction that they're already having. So somebody who may already have an underlying mild cognitive impairment or earlier stages of a process like dementia, what we see is then if they get a concussion, they have a fall, what we see is that while they might not have noticed those problems going on before their injury, then suddenly their brains aren't as able to compensate for the problems that they're having. And so then some of these issues that may have already been going on are suddenly much, much bigger, much more pronounced, and interfere more with their everyday life. I don't think we talked about common ages for concussion. So what we see is that it's most common in the young and in the older folks. So when we're talking about younger folks, it's more likely to be associated with car accidents or sports injuries. And in the senior population, concussions are mostly likely to be associated with falls and again with car accidents. So most patients who have a concussion experience cognitive dysfunction in that early post-injury period. People who are most at risk of having cognitive problems as a result of their head injury, their mild traumatic brain injury, are folks who are athletes who've had repeated low-level impacts that maybe didn't cause a concussion, but still have those kind of repetitive impacts. What we see also is that in athletes, at least, younger patients are more at risk than older folks. Older athletes, so high school athletes, have about twice as long to recover as a college athlete does from a cognitive perspective. Females tend to be more susceptible to cognitive dysfunction after a concussion. And people who have a history of a learning disorder, people who have a history of ADHD are also more likely to show cognitive dysfunction and to have prolonged difficulty with their thinking abilities after having a concussion. Mood changes. So this is a really big one, super common and also very hard to pinpoint in a lot of cases. So a lot of different reasons why folks who've had a concussion may show some psychological changes. So first of all, just the trauma that's happened to their brain, obviously. And again, those neurotransmitters that we talked about earlier, those chemicals that float around in our brains, those get all changed up. And so the way that our brains process those chemicals can cause things like depression and things like anxiety, also more likely to cause things like irritability. So, and then again, anytime somebody's had an injury that changes up their life and how they're able to function in their everyday life, or that causes them pain or distress, causes us to be a little more irritable or more likely to be prone to depression or anxiety, as well as things like disconnection. So a lot of times after somebody has had a concussion and they may be more likely to be overstimulated by their environment, naturally what they tend to do is withdraw, right? And so then they're not seeing their usual people, they're not engaging in those usual activities, and so we tend to see more depression in those folks as well. People who are at more risk of showing mood changes are people who already might have a history of trauma, who already have a history of depression, those who have a family history of any kind of psychiatric problems, and interestingly, those who have sleep problems are also likely to have mood changes with their concussion as well. So things like irritability are super common. So this can be things like just having a low threshold for frustration. So the things that would have kind of mildly annoyed us before the injury, then it's just this big dramatic blow up that they might show after their injury. So more of a dramatic reaction to something that they would have been able to just kind of pass off. Also more likely to be related to overstimulation. So when you feel like, just too much information is coming into your brain, you're more likely to show irritability. Depression often manifests as things like sadness or hopelessness, or just a lack of enjoyment or lack of ability to engage in the things that or relationships that are interesting to them. Rare, but also possible, are that people can have suicidal thoughts. This is especially common in folks who have a lot of pain, especially with headaches. Anxiety is one of the most common psychological changes that we see after a traumatic brain injury, especially a mild traumatic brain injury. It's associated again by this overactivation of the nervous system, also exacerbated if somebody has sleep problems. So you can kind of see how we start to get this constellation of all of these symptoms together, right? You've got pain, you're not sleeping well, you're not thinking well, which makes you more depressed, which makes you anxious, which makes it harder to sleep, which increases the pain, right? So it can become kind of this cycle, and then it's really important that we try to intervene in this cycle. So for those of you who have family members who are athletes, it's really important that we intervene for helping these concussion patients and get them back into school. So it's very important that before they start to return to play, they got to be able to return to school. Because if you can't operate in your classroom, you're definitely not going to be able to operate on the field. So usually we've got a short period of rest followed by a gradual return to activities. Sometimes we need to help folks out and give them some accommodations to help them in school, but the goal is to return them to school as soon as possible, because what we know is that the longer that we're out of our ordinary routine and our typical daily activities, what we get into is then a pattern where symptoms can actually be prolonged even further just because of that lack of activity.
Hi everyone, I'm Dr. Quan. I have a clinical appointment here at Casa Colina in the vision clinic, and we see a lot of patients that have neurologic issues. I want to go over vision and how that can affect one's rehabilitation and recovery. Vision tends to be one of the common barriers to the patient improving. As far as my clinical practice, I am more rehab based. I'm not a surgeon. We're not as medication focused. If someone has an obvious blunt orbital trauma or orbital fracture, that's certainly going to head off to the ophthalmologist for surgical repair. And because we're talking about concussion, that these injuries tend to be more invisible with soft signs. A patient may come in with quite good vision, 20/20, but also have other issues that my job is to look more closely. Get it? Vision, look more closely at what is going on. So the treatment tends to be more rehab-based. We have a strong emphasis on therapy. So versus giving the patient a crutch, we want the patient to get back to their baseline, how they were before they were concussed. We utilize different lenses, prisms, and tints. We touched a little bit on the timeline. And so when a patient has vision-related issues after concussion, these patients need to get in soon. We have a vision clinic here, and we've kind of developed our clinic where patients have more ease of access and also shared communication on our concussion team. So things just move more efficiently versus one piece at a time, so that the patient looking at the whole person can improve more quickly. So access to care is super important, and so we dedicate those time slots here at Casa Colina for that. Vision tends to be very interesting in terms of insurance and what's covered, so not to get into that too much, but we take both vision and medical plans, and that can be a whole nother 3 hours of like, am I covered for this? Am I covered for that? We're here as a resource, and just send your patient, we'll figure it out. The pie graph on the left, the big orange section, that's usually what patients come to our clinic complaining about, blurred vision. The next largest piece is the gray one, and that's double vision. And so with post-concussion vision-related symptoms, the top would be patient coming in, I don't see as well as I did before. In addition to sensitivity to light, double vision, dizziness, eye strain, and also difficulty reading, either slower or difficulty with comprehension. And what is it that I find? With blurred vision, many times with our younger patients with sports-related concussions, what we usually will investigate further is whether or not the patient can focus well. And so patients may end up with what's called accommodative insufficiency or infacility. And that's where if you're trying to read, you're not able to focus. And therefore, there might be some lens interventions that can be helpful. Next common symptom is sensitivity to light. So there is a way for us to test someone's ability to sense flicker and also how the pupil reacts to light and pupillary responses. And research has found that photosensitivity can be due to the patient's inability to adapt appropriately to the amount of lighting that is around. And we can treat with different types of tint to help ameliorate some of those symptoms. Next, we have double vision. Usually patients don't say that they see two of me or two of everyone around them. It might be an overlapping image. And with concussion, we see a lot of convergence insufficiency. And that's where the patient can't cross their eyes in along this z-axis very well. And that's very easy to measure, but it's not going to be really assessed as carefully if you're just going for just a regular eye exam. And so in our vision-based exams for post-concussion, we look carefully for all the high-yield tests that are going to show things that we're looking for that we find a lot and can cause problems. Then you have dizziness, which can lead into vestibular or vision-related balance issues. And there's a term called post-trauma vision syndrome, where the patient is complaining of a lot of the things here that I've already listed, but in just a regular basic eye exam, the patient may find that they're 20/20 and there's no orbital fracture, there's no cataract, but yet they're still not seeing normally as they did prior. And so oftentimes this is a kind of a constellation of things that we find with these patients. And lastly, difficulty reading or ocular motor dysfunction, visual processing deficit. So there are ways to test patients' eye movement skills and assess their level of comprehension and compare it to what they may have performed at baseline. And so this is kind of what I'm looking for and what we find with patients. And here the pie chart is more equally divided. In orange, you see a lot of those tracking issues. The gray is the patient not being able to converge well. The yellow is more peripheral vision issues. And so we see there's a variety of things. So really the patient does need to be assessed within that 2-week, 28-day time frame to see what we can do to remove those barriers to care and recovery. We talked a little bit about the anatomy already, but I thought I'd take the opportunity to point out that on this diagram, the eyes would be here, right, in the front, right, top, superior, inferior, front, and back. So actually your visual cortex is back here. So you have a bony protuberance, if you feel in the back of your head, it's just above there. And so if your eyes are here sending vision information, it's got to bypass all the way anterior to posterior. So the likelihood of damage to our axons and just processing in general, it's pretty likely that you're going to hit some of the vision-related areas, and thus we see 30 to 60% of our mild traumatic brain injury patients will have vision-related symptoms. And all of these areas that are highlighted all have to crosstalk in a very symphonic and efficient manner for the patient to feel like they're seeing and functioning normally. And I coined this 20/20 and unhappy, because that's what we see. These patients are coming in and they're like, I can read that. Yeah, no problem. I can read that. But again, concussion changes post-concussion can be subtle. We find that in our athlete population, they're like, I always had difficulty reading. And so they themselves may underreport what their symptoms are. So it really takes a targeted kind of clinical exam to really look for things that research has shown that that will come up after concussion, and monitor them for recovery. In our evaluation, we have visual acuity, we have focusing testing, peripheral vision testing, tracking of eye movements, convergence testing, and also computerized kind of assessments. So this is not the typical exam that you would normally go for, just if you were to, get your new prescription for the year or your contact lens prescription. This is targeted for what we would screen for and look for after concussion. In our vision screen, just wanted to highlight 2 arrows here. This is our convergence testing, and we also do timed eye movement tests to really kind of measure out where the patient should be in terms of their efficiency. And that might lead to us designing a targeted program for them to relearn how to track and use their vision for reading and or sports and or their occupation and job. So hopefully by now, I've been sitting here for an hour, you're not having some double vision like the top bullet. But I just want to show that this is more overlapping, but it might even be more subtle like this here, where it's just not as sharp, where the alignment is just a little bit off and it's not as crisp and single. And so that's always high yield to measure. And again, vision and balance. We work very closely with the other team members. And so if vision is not coordinated, where the patient is seeing, the input to the brain is also going to be giving bad information for the other systems to recalibrate and relearn what it needs to. We know that sometimes treating the double vision first is going to yield a more accurate and quicker recovery. And so in terms of what is it that we can do, I already told you that I'm not a surgeon. Optometrists, we can prescribe topical medications, some orals, but this is kind of where it's at for me. I love prescribing targeted therapy, corrective lenses if needed. So these would be your spectacle correction to get things clear and sharp. But in addition to those basic things, we may prescribe certain focus-related lenses to help do some of the lifting during that 2-week or 4-week period, or maybe even more of a chronic period where the patient is recovering so that they can get back to school or work. Computer ergonomics. Many of us are on computers hours and hours on end. How long do you think you should go vision-wise before taking a break? 3 hours? 4 hours? It's more like 20 minutes. And so we have to recommend, the 20-20-20 rule. So it's every 20 minutes, take a 20-second break and look 20 feet away. And that can kind of like reset. They even have like timers now built into different programs to remind you. So certainly for our patients during that concussion recovery time, rest breaks, giving them vision strategies for success, colored filters or tinted lenses to help mitigate some of that sensitivity or inability to filter out lighting that may be affecting their other areas of function. Prisms are special lenses to help realign those 2 water bottles into one single sharp bottle. And also allowing for the patient to be successful either back at school or at work by maybe increasing the font size or spacing or giving additional time for testing and things like that. And also patient and family education, because oftentimes our patients that come in for these types of assessments look like they did prior, but yet they're not feeling, and their family member may say, oh, you're fine. So it's also patient education in addition to family education. So because I went last, I have the pleasure of saying thank you for coming to our talk, and thank you to my colleagues, Dr. Cisneros and Dr. Block, and the rest of the team member. We have some of our other concussion clinic team members, Deb Willett from OT, and Kayleen Reed from Physical Neuro PT that have joined us.
All right. So any questions from the community?
What was that 20-20-20 rule again?
Oh, so it's general vision hygiene recommendation. So a vision rest break. So instead of staring at a computer for a prolonged period of time, we would recommend to the athlete to take a vision rest break. Every 20 minutes, set a timer. They would look up and away, so not accommodating and focusing at this 40-centimeter distance. They would look at least 20 feet away. And so it kind of resets the crystalline lens, which is behind your pupil. So just those zonules just kind of just get a little bit of a break versus just, kind of doing that lift the whole time. So we see a lot of eye strain type symptoms in our post-concussion patients. Not so much, but in general, it's a good practice to add if you are reading or working on doing a near point task. It is just a good idea to do. The general working distance, probably at least 40 centimeters away. Your computer, I have a huge monitor at home, but you don't want to be looking up at it. You want it to be just a little bit, actually about 10 to 15 degrees below your line of sight. And again, all of these devices everywhere giving you blue light. Although this blue light isn't going to make you lose vision, but it certainly can affect your sleep patterns. And we already know if you already have likely to have sleep issues, that's going to secondarily make things worse.
Double vision or blurry vision, what happens in the healing process? Do you go back to not having that?
Yeah, so the question was prescribing corrective lenses or prisms. At the end, is the idea to keep those or wean off of those? The idea is always to get the patient back to their baseline where they're not reliant on that additional crutch. But if that is a major barrier for them to get the most out of their rehabilitation, that will help bridge that gap and then wean off if possible.
And I'll also just say that the prism and getting that alignment correct can be truly life-changing. So even without concussion, right? I have a tiny bit of prism in my lenses. Yeah, and it just makes your entire life better. I was getting headaches when I was looking at computers. I was having difficulty reading really quickly. And then I had a fantastic optometrist who said, hey, maybe we should try putting a little bit of prism in your lenses. And everything got better. So, getting in with the right specialist, someone who knows to ask the right questions, do the right exams, and get you the right prescription or the right rehab to fix your vision. As I mentioned, it ties in with everything. 50% of the circuits in the brain, right, have some kind of connection to the visual system. So addressing the vision and getting that properly treated does make, as I said, everything just a little better.
Yeah, so you can definitely see changes in hearing associated with a concussion. Again, usually short term. Also, though, hearing is one of the things that is independently associated with fall risk itself. So if somebody already has hearing loss, they're at increased risk of falls. They're also at increased risk of cognitive decline independently. So super important that if there is already a hearing problem, that we get that addressed to try to prevent the fall, prevent the head injury. I think hearing issues post-concussion are less common, I think, than vision issues, but it definitely can still be an issue. Also very likely to have tinnitus or ringing in the ears that can happen, which can be incredibly frustrating and overstimulating. There's a lot of different things that can be done to try to help that, as far as managing the environment. But that is a symptom that can be associated. You're right, I didn't put that in there.
And I'll also just add that the balance center in the brain, right, the vestibular system, it primarily uses a bunch of hardware and circuitry that is in the inner ear itself, right? So even if you don't just have overt hearing loss or ringing of the ears, you could still suffer like an inner ear concussion, so to speak. So damage to that hardware that tells you what position your head is, that tells you what is happening in the environment as your eyes move around. And that is something that I know Colina actually assesses for really closely from a vestibular or a balance standpoint in the concussion rehab. Yeah, absolutely. I always recommend your primary care knows them the best, right? They have a history. They can basically assess the kind of initial injury, what's going on, and triage it, right? There are pediatric versions of that SCAT5, the sports concussion tool that I mentioned, the formalized assessment. So there's a pediatric version of it that we can administer to our younger patients. So there are special tools for the population that can't communicate as clearly, they can't express themselves as well. They develop special tools for that population. Again, because the incidence, right, the risk is higher in the very young and the older folks. So yeah, but it's important that they get checked out, and I would say primary care is definitely the first place that you would go.
Also included on Dr. Block's slides were there was the red flag section. So if you're seeing any of those types of symptoms, that's really your judgment call of, do I need to really take my grandchild or child to a primary to manage this, or do I feel like overall behavior is similar? They didn't have any vomiting, they didn't have any of those other signs, so I don't feel the need necessarily to take them to examine. But it's always better to be safe than sorry if you're unsure.
Yeah. And any red flags, any of those red flag symptoms, that's an ER trip.
Yes.
Yep. Yeah. Absolutely.